Hello everyone. I hope you are enjoying this event. Today, I would like to share our experience and think about the current state of cardiac reoperation related to congenital heart disease. I have nothing to disclose. Surgical and medical treatment for congenital heart disease has dramatically improved. This article from 2015 shows the improved survival rate of various complex congenital heart defects over time. As a result, nearly all patients have to undergo reoperation during their lifetime. However, as we all know, reoperations are not easy. Patients usually have suffered from suboptimal hemodynamics for a long time. The heart and vessels are riddled with scar tissue, and adhesion increases operation time and bleeding. There are only a few reports that evaluate the results and risk factors of cardiac reoperation. This report from Italy showed a 3.6% mortality rate from 164 adult congenital heart disease patients. Longer cardiopulmonary bypass time, previous operation numbers, and congestive heart failure were identified as risk factors for severe complications. A more recent report from Mayo Clinic analyzed 984 adults with a similar mortality rate. Cardiac injury occurred in 6% of patients, and the risk factors for early deaths were single ventricle physiology and longer bypass time. They emphasized that good preoperative cardiac function had a protective effect. We reviewed all reoperations between 2010 to 2019. Surgeries that did not use cardiopulmonary bypass were excluded. However, bidirectional cardiopulmonary shunts and Fontan procedures were included. Data from the most recent operation was collected. The total cohort was 561 patients, with 60% being male. About half of them were adults. The mean interval from the previous surgery was 12.4 years, and 87% had biventricular physiology. The most frequent diagnoses were TOF or PAVSD, DORB, and TGA. 17 patients had one or more significant preoperative risk factors. 9 patients had combined genetic syndrome, and 11 patients had infective endocarditis. Reoperation and sternotomy counts were as shown. Pulmonary valve replacement and angioplasty were the most prevalent procedures. Also, there were 4 BCPS and 43 Fontan procedures. Operation results are as follows. Cardiac injury during sternotomy occurred in 9 cases. Mean bypass time was 164 minutes. Delayed sternal closure and intra-OP ECMO were performed in 8 patients each. Among the ECMO cases, half of them led to mortalities. Including 8 reoperations and 9 mortalities, a total of 23.4% of patients experienced complications during hospital stay. The most frequent complications were bleeding and deep wound problems requiring re-exploration. The mean length of hospital stay was 14.7 days, and 6.6% of patients had to be readmitted within 1 month of discharge. This is a subgroup analysis of single ventricular patients. Morbidity and mortality rates were generally higher, and length of stay was longer in the single ventricular patients group. However, you have to consider that this group had a lot of prolonged pleural chest tube drain. This table shows the sternotomy count and short-term results of the reoperation. Complications that have a significant impact on the clinical course were categorized as severe morbidities. This includes in-hospital reoperation, CPR or ECMO, mediastinitis, neurologic events that have long-term sequelae, use of renal replacement therapy, and prolonged mechanical ventilation support. Patients with higher sternotomy counts had a shorter interval from the previous operation. As expected, bypass time, complication, and readmission rate increased with repeated sternotomy. Severe complications showed an increasing trend, but were not significant. However, contrary to expectation, cardiac injury and mortality rate did not increase. If you look into the detail, bleeding also showed an increasing trend. The risk of neurologic events and prolonged ventilator care increased with repeated sternotomy. A comparison between the early and late eras shows us an increase in operation age and body weight. Morbidity rate and length of stay improved significantly in the latter 5 years. The incidence of serious problems and severe complications was significantly reduced. A subgroup analysis of biventricular patients shows that the multiple valve procedure group had an overall worse clinical outcome than the single valve procedure group. Pulmonary valve replacement, especially in TOF or PAVSD patients, was the most frequent procedure. They showed a similar result in most areas, but had no mortalities. On univariate analysis, preoperative ventricular dysfunction, longer bypass time, operation on multiple valves, and operation on tricuspid valve were identified as risk factors for mortality. On multivariate analysis, these three factors remained as significant. So what can we learn from all this data? I would like to say that generally, the results of cardiac reoperation are improving. Compared to the previously mentioned reports, mortality rates are low, even more in the recent 5 years. However, the risk of morbidity is still quite significant, which means we need meticulous planning and high-quality post-operative care to avoid it. Preoperative ventricular dysfunction and tricuspid valve operation is strongly associated with early mortality. Therefore, the timing of reoperation should not be delayed at the expense of cardiac function, especially in the right-sided heart. Thank you for your attention.